Welcome to the Behavior Speak podcast. Now, here's your host, Ben Ryman.
Welcome to another episode of the Behavior Speak podcast. Thrilled to have Dr. Nicole Neil in the podcast with us today. She's my first interview as we move into the province of Ontario for some discussions as we get out of BC for what has been the context for quite a few of the first interviews we've done on the podcast. So it's nice to move across the country and nice to have Nicole as our first Ontario guest. So welcome to the podcast, Nicole.
Thank you.
One of the main reasons that I kind of tracked down Nicole was because of some of the work she's doing, in particular with the population of folks with Down syndrome. And there's not a lot of folks doing research on kind of ABA and interventions for Down syndrome in that level, at least that I'm familiar with. And it was pretty exciting to know that someone in our own country is pioneering a lot of this research. Before we got to get to that, Nicole, I was hoping maybe you could just, like many of the podcast interviewers do, give me a little bit of kind of your origin story, kind of how you got into the field, and then what led you to kind of start focusing more on working with folks with Down syndrome.
Yeah, sure. So I started at McMaster in my undergrad, was my first behavioral position. And I took a summer job doing in-home private instructor therapist work. And I started that job. And it was one that was the program was run by the family. So they had privately hired a BCBA. I don't even know if they were a BCBA at the time, but the equivalent position. And I was trained and I worked a few weeks and then the family fired me. And but I got really positive feedback from the behavior analyst working that. So then I pursued practicum with at the time it was called Behavior Institute. So I worked with Cole Walton Allen as one of my first jobs and doing in-home kinds of things. And those positions really sort of led me into the field. I took them because I was doing an undergrad in psychology and thought, I should get some psychological experience if I want to do something in this field. And both of those just happened to be behavior analytic. And so then I went for my master's at Brock and worked with Dr. Tricia Vaz doing my master's there in the Center for Applied Disability Studies. And after that, there's limited options for Ph.Ds in behavior analysis across Canada. Mm-hmm. And I had specific interests. So then I went to the States and I looked in the States for Ph.Ds. And I got into Down syndrome because my supervisor at the Queen's College, the City University of New York, Emily Jones, I had quite a bit of experience in autism, and I've been doing some mental health stuff with Tricia. And she had some expertise in Down syndrome. So we tried to modify some of the things that I've been doing in my master's and apply it to populations with Down syndrome. And that's sort of where the Down syndrome piece came from. And our first set that sort of inspired a lot of the research that she was doing and that I ended up doing for Down syndrome was there was a set of twins that one had autism and one had Down syndrome. Wow. And there was a real disparity in the services that the twins accessed. With the child with autism getting a lot more funded programming and behavioral access, and a totally different set of funding structures and access in place for the child with Down syndrome. So that was always touted as the case that really, really showed the need to continue to disseminate in
Absolutely.
the field. Yeah.
Wow, that's amazing. So it sounds like kind of just going back to your beginning story there. If it weren't for this supervisor giving you some good positive feedback, you might have gone a completely different direction.
Oh, absolutely. Because it was a private family, it was really, I think, the mom trying to find a therapist that she felt comfortable with. And, it totally makes sense. And I just wasn't that person. But the supervisor said, you have skills. Just because this family isn't the family for you doesn't necessarily mean that there isn't another family out there that you would work well with.
Mm-hmm. No, that's really good. I think that's sort of, I know that's not really the topic today, but that speaks to kind of really good supervision, because I think there is a piece kind of around contextual fit and families and interventionists meshing well and just trying to find a good match there, and kind of being able to understand sort of early on in the career that having the skills and maybe not matching with the family is fine and normal, and lots of other opportunities. So that's really cool.
Absolutely. And you're in someone's home, right?
Yeah.
Like you're there in their most private, personal kinds of life. So I totally understand if you're like, even if it's just a vibe, right? Like I get it.
Yeah, totally.
I don't really like this person here. Totally. I understand.
Yeah, they may have been just looking for a particular person. I know I've been talking to, as I've been kind of doing my supervision, I've been talking to a lot of folks that they're working kind of with families, and these supervisees of mine are young; they're in their like early 20s, and these families really want people that are older because they think age is sort of equivalent to wisdom and skills and training, and so they're often asking for the older consultant. Can you bring the older consultant in? When in fact it's probably more likely that the younger one actually has more training because the programs weren't available for some of the older folks. But yeah, no, that's interesting. Yeah, I really like the piece about the twins. That's an amazing sort of twist of fate to sort of be presented with a set of twins and have that experience.
Yeah, they had that family had been working with that lab group for quite a while.
Mm-hmm.
And they started because of the child with ASD participating in some interventions. And that prompted them to say, hey, maybe we can do stuff for this other sibling.
Totally. So maybe we can kind of start with just some more understanding of Down syndrome. I mean, we know it's a genetic syndrome, and the cause is identifiable, unlike autism, where they're still sort of looking at all the different possible causes. It's pretty straightforward. It's Down syndrome right from the beginning. And so there's certainly some potential there for even earlier intervention because right from birth, and we can kind of touch on that maybe a bit later. But what is it? We know a lot about autism in this field. We know about sort of those three sort of core areas of social skills and language and repetitive behavior. What is it about Down syndrome that makes ABA kind of a good treatment?
Yeah. So typically when I talk about like the expression of Down syndrome, we talk about the behavioral phenotype. So you've got your genotype, right? Your genetic makeup, and how that gets expressed as your phenotype. And in a lot of the sort of developmental literature, they talk about a behavioral phenotype, which is less, maybe a little bit less direct when we're thinking about physical things, right? You have the gene for blue eyes, you get blue eyes. But with the behavioral phenotype, we're talking about a probabilistic kind of outcome. So they may be more likely than people with other genotypes to display these characteristics, but it's not Down syndrome gives you these behavioral ones. Right. So it's a little sort of softer in terms of directly related, but we're kind of familiar with that with autism because there's a blend of expression, right? And we get the same thing. So I think that's really important to keep in mind that, maybe because of the genetic makeup, we think of Down syndrome as a little more homogenous, but there's quite a bunch of variability within that expression in itself. So that's the first thing I'd say is that there's a lot of differences. And then you can even get into things like mosaic Down syndrome, where you have parts of your cells have trisomy 21, but other parts, like other cells, do not. So
wow.
that will also affect expression. But things that we see in Down syndrome, one of the biggest areas that I think behavior interventionists would be focusing on would be the language. So we see pretty early on some difficulty with expressive language, a lot of language delays in articulation, in things like tacting and manding, and just expression in itself, relative to their expressive or their spoken language. They're stronger in receptive language, which I think is true for a lot of intellectual disabilities as well, or not all. There's a couple, but for most of them. So relative strengths in receptive compared to expressive, and relative strengths in like pragmatic, so social use of language. So the nonverbal kinds of things. And that's where you get those sort of stereotypes of being charming or sociable or outgoing, right? So a lot of those social pieces tend to be strengths compared to the language pieces. We see quite a bit of difficulty in cognitive functioning. So verbal short-term memory, doing really long, extended task analyses can be difficult, holding information in short-term memory and working memory. So if you're giving, multi-step instructions, we see a lot of breakdown when we get to longer steps. I haven't had a lot of success teaching really long steps without some kind of support to individuals with Down syndrome. The other area that I've done a bit of work in is what they call task persistence. So we see a lot of variability in how they respond on sort of, standardized tests. And then when we think about what we're doing in behavioral kinds of settings, right, when we're giving repeated tasks, we see a lot of variability. So, they'll do an IQ test or something like that, or they'll present a task. And on the first one, they'll perform, with relative strengths in certain areas and relative weaknesses in other areas. And then on the next one, we get a totally different pattern of responding. What they call it, I don't know if I necessarily like the term that I've seen in the literature, but they call it like opting out of learning opportunities, which I don't necessarily think that they're choosing not to do that. But
right.
But when things are really difficult, we see this real variability in responding. And so they call that poor task persistence, that they don't push past difficult things, or that they're presenting a lot of challenging behavior for task-related demands.
Does that mean that maybe, that's interesting. Does that mean that some of these kind of standardized testing tools that you're using to measure these things may not be sort of working properly, because you get to sort of task 2 to measure something else, and for whatever reason they're less interested and less motivated in kind of doing the task? Is that just sort of speaking to the task persistence, or is that speaking to their ability to do the task?
Yeah. I don't know. I think that's a good question, right?
Yeah.
I think that's not unique to Down syndrome either, but it is something that is particularly noted in the literature, is that, the context of these standardized tests and their applicability to people with really significant intellectual disability, it's challenging to get a good picture of performance, especially, there's ones that you can choose that are better, that are easier for people without a lot of language. But, the standard WISC relies a lot on expressive language and verbal short-term memory. So I don't know what you're getting, except, that they do have an inability to do these particular tasks. So, and there's better ones to pick that modify that a bit, but it's still really challenging to do these IQ tests with people with significant intellectual disability.
Yeah, for sure. And so with all of this behavioral variability, unlike autism, I think on some level, I mean, certainly, we know autism is a spectrum, and there's lots of different presentations there, but there does seem to be well, you don't get the diagnosis without sort of those core characteristics, whereas Down syndrome, you get the diagnosis from the genes in the cells. You don't get it from the behavior, right? Is that kind of how it works? Yeah. Is it essentially a blood test, or?
Yeah. So it could be like if a mother does prenatal testing, right? They might get it at that point.
Right.
And then oftentimes they'll notice at birth because there are physical features that are obvious, right? And then they'll do testing afterwards to confirm that.
Right.
And that would also confirm, right, if they had a mosaic or the trisomy of all their cells.
Yeah. Some of the stuff, like there's also some like interesting kind of. I've only had one client, I think, that I worked with that had Down syndrome, and he had, which I don't know if this was sort of a generalized characteristic, but he had there were sort of things physiological, like around like swallowing and the tongue and kind of those sorts of things. Lots of folks with the tongue kind of sticks out a lot, and so and of course all of that obviously affecting swallowing and eating and whatnot, but also affecting speech in a lot of ways. And so we have a lot of folks that can speak, but they're hard to understand. But you're saying it's not just sort of an inability to understand them, but there's also actual language deficits.
Yeah. So there's definite medical and physical associated characteristics, right? So enlarged tongue, that's where you get some of that tongue protrusion pieces, and the muscle tone issues. So there's low muscle tone, which results like in what looks like relaxed or lack of strength, which probably plays a role in things like tongue protrusion. But then things like the flattened facial profile, right? If you're thinking about the airway passage, there's differences there. And so all of that is going to contribute to the expressive language challenges, right? So you see a lot of work done on articulation for kids with Down syndrome. And then in addition to that, there's these expressive pieces that go along with it. And they are going to feed into one another, right? Like, what's the point in talking if nobody understands me? Right. So if I'm having difficulty with articulation and every time I say something, I have to repeat myself 4 times, well, now I've got a much more challenging situation. And so I might not engage in that behavior because it's not going to be very rewarding to repeat myself a bunch of times.
Yeah, for sure. Yeah, I know. Again, it just reminded me actually of there's a second young lad that I kind of supported recently, not directly, but kind of took a side job of just kind of now that living on the West Coast in the land of great hiking. I took a side job just taking kids with disabilities out for hikes, so I could get paid to go to the forest and enjoy the air. And one kid in particular I used to take out quite a bit, and he had such amazing patience. Like no one could understand what he was saying, and he had to repeat himself, like you said, 4 times, 5 times, 8 times. But he would happily do it over and over and over and over and over again until you figured out what he was saying. And it just blew my mind, sort of the lack of frustration and the acceptance that people don't understand what he's saying.
Yeah, and I would say that's probably not necessarily characteristic of my experience, but of course those people probably wouldn't be coming for intervention as frequently either. But you do see like there's that social stereotype, and there's a lot of socially motivated, socially directed behavior that is present and is intact, unlike autism. And so if you're really motivated by people, then maybe you'll keep going because it's worth it.
Yeah, absolutely. And I think this is why, we probably see, at least I've seen from my experience, a lot more folks with Down syndrome having success getting jobs sort of later on because, they're such such social creatures that that they really just sort of change the vibe of the workplace. And you see, I mean, we've seen there was I think there was a great documentary on TSN about a fellow with Down syndrome who works as the kind of equipment manager for one of the major NHL teams, and they just love him. Like he's like just like the greatest thing that ever happened to that sort of sports club. Whereas we don't always see that with our autistic folk. Another sort of piece here around kind of the variability is, I imagine, again, kind of lots of autism comparisons here, but generally you get an autism diagnosis and sort of the messages get them into therapy as quick as possible, whether it's ABA or not, it's get them into some kind of intervention as quickly as possible because early intervention is so important. But where with Down syndrome, if there's this variability, is it still the thought that they should all go into some kind of early intervention?
Yeah. So I'm going to pull from the New York State education guidelines because that's the one I know from my Ph.D. But I know the recommended guidelines that were published years ago by the New York State Department of Health for 0 to 3, they were recommending things that are early behavioral intervention as well as early speech and language therapy. I think it's really based on what presents. I don't think we have the same recommendation in Ontario, but that's one of the only ones I know of where they specifically put that as a state guidance. But whether it actually happened is different. So I definitely don't see intensive early intervention being recommended. And I honestly don't think I would necessarily recommend something similar to what we do with ASD for kids with Down syndrome. But targeted interventions based on specific presentations. So there's often a lot of early medical interventions that have to happen. A lot of the kids I've worked with have had heart surgery very young. So that's sort of number one is stabilizing medically. And then there's a lot of those motor things that come early on. So you're seeing a lot of OT-PT work being done because of walking and using and motor planning and visual motor control, all of those kinds of things early on, because that's going to be something you notice pretty quick, right? Is that they're not walking or they're delayed crawling, those pieces. And then we start to see the speech things come in. So you'll see a lot of early speech language intervention that will happen as well, because when you don't start talking right away, right, that's the first thing you think of.
If you're collecting CEUs for this episode, you'll need to know the 3 secret words. The first secret word is down. And so with sticking maybe to New York as the example, and then we can move local, they have these recommendations. And so do they therefore have funding?
Kind of. It depends. There is some funding through education. I know the family, it might have changed. I've been out of New York for a few years now, but at least at the time, the people that we were working with actually took our research and got funding from the Department of Education for hours of therapy.
Amazing.
Using the data that we had. So sometimes, I think, but you have to be pushy.
Yeah. And
in Ontario, the funding, most intervention funding, it's like any other diagnosis. So a lot would come from, if it's school, you can access some of it through school. And then insurance, and there are some, small funding pieces, but there's no Ontario Down syndrome program or Ontario intellectual disability program where you can access funding and get everything that you might get if you had the diagnosis of autism.
Right. And for those listening that maybe don't know Ontario, you guys have the Ontario Autism Program, which is basically your funding model there.
Right.
Why isn't there more research on Down syndrome? It's awesome that you're pioneering this. you're obviously, young, and you haven't been in the field that long, but you're doing this great work. Like, why isn't there more? There's tons of research on autism, and we know ABA is not, it wasn't even sort of created for autism initially, I don't think. And so, what's going on?
I'll do a lot of speculation, but I don't have any evidence for the things I'm saying.
Sure, of course.
I'll put that out there first. I think there's a lot of contributing factors. I think one, the presentation of Down syndrome is not as immediately urgent problem. Like the problems that they're presenting are not as immediately urgent to families in the same way that severe challenging behavior that's present in other diagnoses is. So I think that's one contributing factor. You have a happy, smiley baby. There's lots of information about Down syndrome present, on the internet and in books. We've known about it for a long time. You're seeing things like, the guy in the NHL with these positive stories.
Yep.
And so I think there's generally a slightly more positive stereotype or halo. And when you don't have those challenging behaviors, there's resources available that meet their needs. So, we can improve in certain ways, but a lot of the things that they might be getting might be helping, right? Or are helping. And that's working for them. Mm-hmm. And then I think in terms of thinking about the field of behavior analysis, there's a little bit behavior analysts, we think everything's similar a lot of the time, right? So yes, the basic principles of behavior analysis are fairly universal, right? We know that reinforcement works and does something, whether you're a rat or a human, or, whether you have autism or you don't have autism. So some of the feedback I've received in the past, even when submitting articles, is that, well, why would we care if you're doing the same thing that we've already established for another population? Because of course it's going to work. We know that. And so I think that's a challenge. And I've read and I've pulled quotes from other articles where they say, EIBI is effective, early intensive behavioral interventions effective for kids with autism, and therefore it should be effective for all kids with intellectual disability and developmental disabilities, without considering some of the nuance of, one, needing empirical evidence to establish that. And two, just because it's likely to work doesn't mean we know the best way to do it yet, or the best things to target within it. So I think there's some challenges that come from our field that push down this literature a bit more, because we, in my opinion, it's a little bit arrogant to think that, yes, it will work with everyone, everything, all the time.
Okay, so with that, you're doing some work. What are some of the things you've been working on?
So the things that we've been doing in Down syndrome, my specific area that I've done a bit of work in is looking at intensity and how to consider intensity. And that sort of started with this idea of do kids need this intense intervention, trying to establish that providing more intensive interventions for kids with Down syndrome would be beneficial. And I did this more in the context of almost like a basic type replication, where we were looking at the pacing of instruction and seeing, if we change the number of trials, if we change the pace of instruction, if we change the length of sessions, how does that affect learning? And we were doing it with verbal behavior. So some of it was listener responding, some of it was tacting, some of it was interverbal kinds of things. But it was done in quite a traditional discrete trial approach. And that was because you have to keep a lot of things similar if you're doing pacing work. So not necessarily the way I go about practice kinds of things, but it was necessary to answer the question.
I see. So it's not that you think discrete trial training is the way to go for kids with Down syndrome. It's just a lot easier to kind of measure intensity and dosage.
Yeah, exactly. And honestly, my work is the practice that I would recommend for kids with Down syndrome is inclusion full on, right? Which I recommend for all kids, but yes, definitely inclusive things. And I think the low intensity, but not too low intensity, more naturalistic kinds of approaches would also be beneficial as well, given my experience with the population. And that's mostly because of they have really strong social skills and modeling skills. And so just throwing them in a classroom with other kids, they're going to pick up a lot of behavior. And then you can focus in on those specific things that are giving them trouble, right? And present those trials embedded in a classroom or a daycare or something like that.
Right. So they probably would do well with things like peer mediated learning and that kind of stuff.
Absolutely. Yeah.
So what did you find? What have you learned about dosage?
Nothing. No. What I learned is it's really hard to study dosage. So the sort of the work that we did actually ended up being a lot more methodological kinds of questions and answers from that. So when we think about dosage, right? Like if I want to increase the pace of instruction, so I got 10 trials.
Yeah.
I want to do them, 30 seconds apart, or I want to do them 1 minute apart. So I want to compare those. So when I do that, unfortunately, another aspect of dosage is yoked to that, right? If I increase the pace, my session becomes short. And if I decrease the pace, my session becomes long. And so I've got an uncontrolled variable there because it's intrinsically tied to that pace piece. So, okay, now if I want to hold the duration the same, well, I either have to do more trials, right, to fill in that gap. So then I have a trial problem. What's more important? So our work was trying to figure out, like, could I tease these apart if I came up with like a matrix and said, in this set of conditions, I'm going to hold the time the same or the duration the same. If this set of conditions, I'm going to hold the inner trial interval the same. And in this set of conditions, I'm going to hold the number of trials the same and do some figuring out to make sure I have some overlap so that I can figure that out. So that was our goal. And we tried to do it with like some single subject work, and it doesn't quite work out. And I think you need like some randomized pieces. And in the end, I just pointed out how we have to be really careful when we read some of these pacing studies, and thinking about that there's all these additional variables when you go in and you review intensity work. Oftentimes there's this confound of duration versus trials versus spacing between them. So be careful with that. And two, I don't think there's one pace that's the best. So faster pace works for a lot of stuff. And we see that, right? You can look at precision teaching and fluency work, and that'll holds up basically. But I think it depends on the kid. And my thoughts, we tried to do a little bit of it, but thinking about, can you do like some kind of brief assessment to decide what pace is going to be helpful for a particular response or teaching program? Because I think it's going to change too much depending on the program and the kid, what you're trying to do. And so, could you do like a mini functional analysis and present 2 paces and see what results in better responding for that kid? The same way you might do like a prompt assessment. Could you present 3 prompts and see which one works the best? You could maybe do that with something like pace and session duration and those kinds of things.
So are you continuing to study dosage, or was that sort of stuff you were doing and now you're doing some other things now?
I have a little bit sort of on the back burner with that. Once I can get in front of some kids again, I'd like to continue to do a little bit of teasing apart some of this stuff. But I would say it's more of a sort of a translational kinds of project, right? It's thinking about, what's the what's the perfect pace? I don't think that exists. So it's exploring how to actually study it well.
Yeah. You chose again discrete trial for more again for its the ease of measuring these DVs, but you wouldn't use that method to actually teach kids with Down syndrome, and so why not?
Yeah, I mean, in general, I'm not really a huge fan of controlled tabletop discrete trial stuff. And that's mostly because I'm lazy at generalizing, right? Like if I do it all at the table, then I got to work to put it somewhere else.
Right. Fair enough. Yeah.
So that's part of it is that, let's cut down on the context changes and let's do it within context. I really think, as much as kids can learn from other kids, let's take advantage of that. And that's going to help with all the other things like stigma, like understanding of their diagnosis, ability to make friends and learn from friends and all of that stuff. So I very much think, get them where they need to be. And then can we embed those opportunities in the places that they need to be as kids?
And I realize this is speculative and you don't necessarily have the research to back it up. But do you think that that's sort of the case all around with discrete trial training? Because I think with kids with autism, they already struggle with generalization that's sort of like a key feature for them in a kind of a clinic setting or whatever, and then have to go and do it all again, at the home, at the school, at the park, at the pool, and keep doing that. This is more of a maybe philosophical question, but why is discrete trial training still so popular?
I'm not I don't want to trash on it totally. I think there are maybe some contexts where it might be important, right? Like when we're talking about fluency kinds of things. Yeah. Sometimes a little bit of drilling is going to be helpful, right? Sure. In the same way, there's the talk, kids don't learn their times tables. They learn about the why of doing multiplication. And I think you need both, right? You need to be able to be fluent, because if it's taking you 20 minutes to get to an answer, it's very hard to do the other stuff. But for the most part, especially when we're talking about these socially significant responses, then I think teaching in context is going to be the best bang for the buck. I just think it's hard. It's really hard. Anyone who's run naturalistic play sessions and that, you got to be on the ball all the time. You got to be really thinking, and it's difficult. So that might be why. But yeah, there's a time and a place for some discrete trial, but for the social stuff, let's do it with other kids.
The second secret word is Western. Yeah. And so are you using, because I know there are quite a few of these sort of naturalistic developmental behavior interventions, they call them, out there, where they're essentially all, in the natural environment, and they're often kind of child-led and learning opportunities are natural versus contrived. And so I think of things like pivotal response training, or the early start Denver model. We just released a most recent episode on that with Maria Sample, kind of talking about ESTM. Are you using kind of any of those particular frameworks, or are you just sort of just doing things in a context?
Yeah. I mean, most of it. So not right this moment because we're socially distanced, but but before that, we were running sibling programs with kids with Down syndrome, and so we were working on play between kids with Down syndrome and their siblings, and so we were targeting it in the context of traditional gym class kinds of things, and so we were embedding those opportunities to practice their language and requesting and things like that with their siblings. And it was a group intervention. So it would be, they could practice it with siblings of other individuals with Down syndrome as well. So that kind of mixed peer group. So those kinds of things, but we don't use, the principles are there, but I'm not, using a package that I would say, but it's the same ideas, right? And there's quite a bit of work from a group of people in Down syndrome that use milieu communication training, which, has behavioral roots mixed with some developmental theory in there. So that kind of idea, right, of this, similar to like the Early Start Denver ideas, where they're mixing these sort of developmental approaches with behavioral principles.
So how did that sibling program go? That sounds really neat, like using the siblings.
Yeah. So that one was a replication of something that was being done in New York with kids with ASD. And my first years at Western, my first 2 students replicated the program in a pilot project with siblings, one who had Down syndrome and one who did not have a diagnosis of Down syndrome. And the program was, the first hour, we would do some work on, we would separate the sibling pairs. The kids with Down syndrome would do some work on things like requesting, initiations with an interventionist, like a pullout. And then the siblings without Down syndrome would go to a support group with, my students are in counseling psychology. So just talking about what it's like to have a sibling with a disability and what that means for you. And then we would bring them together for the second hour and practice those same language targets and social targets for the kids with Down syndrome with their siblings. And the siblings would practice some of the things that they had worked on, which might be, some things related to patience, or even some of them doing some prompting and things like that as well.
How old were these kids?
6 to, I feel like our oldest was around 14.
And the siblings, though, were they all?
Yeah. So it was mixed. I find it works best if the siblings without Down syndrome are more similar in age, because it's hard to run a support group with a 7-year-old and a 14-year-old.
Absolutely.
So my experience is if you can match that group, that does better. So you want, a bunch of teens, or you want a bunch of school age kids, because the dynamic doesn't quite work for support. It's hard to get support from a 7-year-old if you're a teen. Absolutely.
And I can totally see the value of this for the kids with Down syndrome. Just to be able to have their own, family members kind of helping them learn, and they often look up to their sibling, and so, they provide there's a lot of motivation to sort of model that person. I'm wondering what I imagine there were some, like what were some of the benefits for the siblings, kind of to have that ability to kind of get together and get that counseling and just kind of connect with other siblings.
Yeah, absolutely. Sometimes just being acknowledged, I think, is a benefit first and foremost. Just saying, someone else who can say, yeah, I get it. That's a big piece. Just knowing that you're not alone, that other people have the same experience. And we always had a guest speaker who was an adult who had a sibling with Down syndrome come in and talk to them, which I think was really great for especially those in the teen transition years, where, they're thinking like, what's it going to be like when I go to university? And I really want to leave home because I don't want to feel responsibility. And so talking to someone who had done that was always good to see, okay, my future looks or could look like this, and it'll be all right. And then we also worked a little bit on coping strategies. So thinking about when you're frustrated, what can you do? Or how do you ask for your own time? Because a lot of caregiving goes to siblings. And so you might not think of that as a parent because you need help. And so you're asking your kid for help a lot. And so then being able to advocate for themselves and that need for balance, and parents are aware, like they don't want it. They don't want to put everything on their kid, but having the ability to recognize and say, it's too much for me, or I just want to be a kid today. And can I have that, mom or dad or whoever, right? So things like that, having coping skills, how to deal with when people say things, how to deal with when your brother or sister does something that annoys you. And honestly, the skills are like, I don't know if you have siblings, but those are things that sometimes I needed help with too, right? It's
Absolutely.
like how to tell my brother to step off.
Using that language.
Yeah.
It really brings up a lot of really good points about sort of the effects of on the family and on caregivers and that sort of thing. And I noticed in one of the links you sent me that you recently published a study on kind of some work around the support needs of caregivers.
Yeah.
Yeah. So what did that study look like, and what'd you find there?
Yeah, that was a great study done by I have another one we're working on publishing. So I had 2 students working on these parallel theses. One did a qualitative work, one did quantitative work. And the one that's out is the qualitative one.
Yeah.
We were actually approached by the London Down Syndrome Association to help support them in putting together a parent support group. So that's how this project started. And so my 2 students, both Masters of Counseling students, took this on. They put together a support group for the parents that they facilitated. So they would get guest speakers, and then they would also mediated time to, just chat with one another. So it was a blend of that. And then as part of their theses, they wanted to do like a needs survey so that they could pass that on to Down syndrome advocacy agencies if they were designing their own support groups, or they wanted to say, hey, let's lobby with this information, or let's ask, at least we have some data to support it. And so the qualitative one, she interviewed families of parents or caregivers who had a child with Down syndrome, any age could have been. And then she did a participatory approach. So she took all the interviews, she pulled out what we call unique statements. So they were different sort of in sentiment and content from all the other ones. And then she handed those unique statements back to the families, and the families sorted them and created categories and also rated them on how important that they were. So whether they thought it was a need for families. So the families did the data analysis kind of.
Really cool.
Because they did all the sorting of that to come up with the themes. And then we used a program it's called hierarchical cluster analysis, where it basically calculates the distance between all the ratings and sortings of what the families gave us to come up with a map. So we have like an average distance between all of those, and that's what the map is in there. It's a really cool kind of approach. And so all the themes that came out of that are actually right from the family. They decided that that's what they were, and that's what categories they should go into. And so we see, to me, it's not particularly surprising what we see, right? We see it from a lot of caregivers for people with any disability. Big things being, financial support, which even with funding, we still see that among people with autism and their families. So the inconsistency with having to rely on private insurance. So if you have private insurance, then you seem like you get a lot more, but it's really hard to find them, and it changes with age. And so there's a lot of difficulty with financial things, and a lot of desire for some kind of streamlined process, right? Like, they want speech, they want OT, they want PT, but they feel like they have to dig for everything. And that if you get a good sort of case manager type person or a good person at school, then you get the things. But if you don't have that person to help you navigate, then you feel very lost.
Yeah.
So hidden kinds of programming is what they feel like. Yeah. And then education, right? And again, I think that's a challenge for people with kids with disabilities in general, right? Is some school boards you get an EA and some you don't. And I know for a lot of families with Down syndrome, because their child doesn't have significant challenging behavior, they go lower on the list for things like an EA.
Yeah, of course. Yeah. You've touched on this a couple times around kind of private insurance. What sort of things does private insurance cover?
Well, I think that depends on your plan too, right?
Yeah.
Like it could be like $15 a session or something.
Right.
Depending on what you get. So sometimes it might cover some portion of speech or OT or PT.
Oh, okay, I see.
But it's who knows, right? Like
it varies, yeah.
Depending on your job or where you're getting this from. At least my experience, it's like some measly amount per session, right? And same with psychological supports, right? Like if you have a mental health diagnosis and they cover like what, $20 of your $200 therapy session?
Yeah, it's ridiculous sometimes for sure. Or they give you a lump sum, but it's so small and the therapy session is so expensive that you end up getting 2 a year or something.
Yes, exactly. Yeah, you get 2 or 3 and you better be better by the end of it.
Yeah, exactly. Yeah, so it's not like sort of the States where they have, I can't even begin to fathom it. I often just zone out when webinars talk about licensing and licensure and insurance and coding and all that sort of thing, because it's confusing, but it does seem like the at least in terms of autism services that insurance covers a whole lot more.
Yeah, and that's because of the advocacy, right? So the families really advocated and they got that written into the insurance laws that those things had to be covered. And
similarly, that's kind of where things like, I suppose, I mean, I can only speak for BC, but I presume that's where things like the OAP kind of came from, was probably advocacy.
Yeah. Those are families. Families did all that work and got those things for themselves and their future families.
And so what is that happening in Down syndrome? I mean, and as a kind of a related question, because I know that the sort of the prevalence of autism just keeps going up and up and up every year. And I don't know, we're in the sort of 1 in 40 or 50 now. What's the prevalence of Down syndrome? And then also connected to that, is advocacy for services kind of happening?
Prevalence of Down syndrome. I'm trying to think if I know the exact number. I feel like, and we maybe have to fact check this, it's somewhere around 1 in 1,000, somewhere around there. So if I'm wrong, I'm sorry, world.
But a lot lower than autism.
Yes, definitely. In terms of advocacy, there are fantastic advocacy groups. That like Canadian Down Syndrome Society is amazing. I've gone to their conference and done they shared some of our research on the caregiver stuff. And then, I have a few families that have reached out to me in terms of thinking about, behavior analysis and getting behavior analysis for people with Down syndrome. And we work a lot with like the London Down Syndrome Association. So I think there's a lot of strong advocacy groups and they're working towards things, but it's different. I don't know if they're as loud as the families with autism were, and they might have different priorities. I think they're really strong advocates for a lot of inclusion and thinking about inclusion in schools and inclusion in the workforce and those kinds of things, which I think are really good priorities. So, and I always say, I'm happy to support them, whatever they I can do, whether it's research that supports that, I'll do it.
Mm-hmm. And I think and kids with autism seem to just, and we already touched on this, but they seem to do, they seem to do a lot better in inclusive settings than kids with Down syndrome do a lot better with in inclusive settings than say some kids with autism that have a lot of severe kind of challenging behavior, I suppose.
Yeah, I think, I would argue most kids are going to do better in inclusive classrooms. But yeah, if there's with the right support, right? So severe challenging behavior, we need to address that. And there's really good procedures for doing that very quickly. I mean, look at Hanley's group is getting severe challenging behavior decreased in 30 hours, and then they're able to be in the classroom, and it's all set to go. So I think with the right support, we can get all of those kids included.
Yeah, and maybe I kind of worded my question wrong. It's not so much that kids with autism wouldn't do well in inclusive environments; it's that they're less welcomed.
Yeah, I think especially when you get that challenging behavior, right? Like the peers and the families are resistant, and the families too, right? It scares me to. If I was a parent of a child with severe challenging behavior, it would be very scary for me to throw them in a classroom without knowing that they had support, because the last thing I want is for my kid to hurt themselves or hurt someone else, right?
Yeah.
So I think that support piece is essential, and we have it. It's making sure it's accessible.
Is challenging behavior... I mean, obviously, challenging behavior is something we see in every kid, whether they're, diverse or not. But is there, enough kids with Down syndrome that have challenging behavior that we see some research in that area too?
Sure, yeah. So the research on Down syndrome is a little difficult sometimes because, one, a lot of the prevalence kinds of studies for things like behavior problem or sleep problems or whatever, they always use Down syndrome as the control group to kids with ASD.
Huh.
So they go, kids with autism have more challenging behavior than kids with Down syndrome. So relative to kids with Down syndrome, this is what kids with autism are like. And so then it's like, well, what about these guys?
Yeah.
Do they have more or less, or is it more prevalent? So there are some that do comparisons between those, of other intellectual disabilities and that kind of thing. There is less, but it's not zero. And it may be less severe. I'm sure many people who have worked with kids or adults with Down syndrome have experienced the stereotype of stubbornness, right? That they're very stubborn, very set in their ways. That's kind of the commentary you get a lot from the public. So yeah, there's some issues there, right? In terms of task completion, pieces like that. We don't see... I mean, I've had a couple that I've seen things like aggression, stereotypy, but much less frequent than other things. What we usually get is a lot of, all kids have transition issues, those kinds of things. We see a lot of sleep things going on. So, milder in topography, but not necessarily less present.
Right. The third secret word is teaching. And then I think we also sometimes will see cases of folks with Down syndrome that also have autism.
Yes.
And then and I wonder what sort of the outcomes look like for them, because obviously they get that autism funding and they get that autism programming, and I wonder, does it also address? I wonder if they see how that kind of addresses some of the other pieces of Down syndrome.
Yeah. I would imagine. I don't. There's not a good set of literature on that, and I don't even have a good sample, like personally, to draw on. I know of a few, and the diagnosis sometimes is really complicated too,
Mm-hmm.
where you're not even really sure if they should have the dual, like, there's definitely some that have the dual diagnosis, but it is challenging to differentiate between intellectual disability associated with Down syndrome and those characteristics associated with autism. So that's a challenging diagnosis to give. So I don't have a lot of exemplars of that.
No, for sure.
The other thing I was going to say related to like research in Down syndrome that's challenging is that oftentimes in behavioral literature, they get lumped into intellectual or developmental disability in general.
Yep.
So like when we did reviews, they were one in a group of 3 kids, but it wasn't focused on Down syndrome. It was just focused on a particular behavioral technique. So if you're looking for research that includes people with Down syndrome, it's hard to find because you can't just search Down syndrome because it's embedded in the participant section. So it's people with intellectual disability or developmental disabilities. So there's lots on challenging behavior, but they're one of 3 participants.
That's interesting. And so is because one thing we're also seeing now is a lot of the kind of autistic self-advocates are speaking up more now, which is great. However, some of them are also speaking up kind of against behavior analytic kind of interventions and whatnot. But most of those, probably all of those folks that are speaking up don't have any intellectual disability. And so, and often they're kind of in some ways, maybe not legitimately, but they're speaking for the folks with intellectual disabilities, which brings a whole other level of challenges that maybe those folks aren't considering. That makes behavior analysis a really good intervention for those folks. I don't know really where I was going with that, but just kind of pointing out that, like you said, like it's we often lump together intellectual disabilities, and often intellectual disability is assumed in autism. Is intellectual? I guess the question is do all folks with Down syndrome have an intellectual disability?
Most, at least 3/4, probably more, much higher than I would say autism. So it's a lot of them. And
going back to your point there, that there is a lot of research on interventions for intellectual disabilities, and like you said, if you looked in the participant section, you might find a few folks with Down syndrome.
Yeah, that's what we found is when we did that review, there were a lot of participants with Down syndrome present in the literature, but it was not an article on people with. It was not specific intervention tailored to their needs. Yeah. It was, I'm doing task analysis and I'm establishing it with people with developmental disabilities. And there's one person with Down syndrome present in the participant section.
And so did you notice sort of whether in that research, whether those participants with Down syndrome, and obviously you would have had to do a lot of reading and ruler on the page line by line, whether those folks with Down syndrome were getting good outcomes from sort of the generalized intellectual disability intervention?
Yeah, that's exactly what we did. I pulled all the behavioral literature and I went line by line and pulled out every person with Down syndrome.
Yeah.
And then we did a meta-analysis.
Awesome.
And yeah, there's no difference. Like, we're getting good effects where there's a lot of literature where they're included for one like challenge decreasing behavior. So challenging behavior. Mm-hmm. There's a lot of work on communication present in the literature. And so I can say pretty confidently that, these strategies are likely to work for individuals with Down syndrome and my experience is that they do. But I think the part that's missing is that piece about tailoring and considering those unique characteristics, right? So when you lump everybody together, you are limited in the areas that you can target because they have to be present across all your participants. So, challenging behavior is universal across developmental disabilities. It's happening across all of them. And expressive language is usually a thing that's an issue across multiple developmental disabilities. But then we're not using those things that we know about, the relative social strengths and the relative strengths of the population to design an intervention that's tailored to them. So that's what's kind of missing, is if I know more about this particular diagnosis, I can do a really good intervention that is targeted, that targets the critical pivotal skills or those behavioral cusps for this particular group of individuals. And that's what's missing from the Down syndrome literature.
And I know we kind of, I think, already touched on some of that already, but I think it would be good for listeners just to kind of hear again, what are those things?
Yeah. I mean, one of the big things that I think about, so when we're talking early intervention, we all know that for kids with ASD, joint attention is like one of those things, right? That it's kind of that skill. Establishing that skill is going to open up new opportunities to them because they're going to engage with other individuals. It's a core feature. Well, kids with Down syndrome are really good at joint attention. They actually use joint attention to escape task-related demands. In the literature, they call it party tricks. So you have a kid who has Down syndrome, you present a hard task to them, and they go, look at that. And they point and they smile and they laugh. And you go, oh, that's really cool. And you stop doing work with them, because who can ignore a cute little baby pointing at stuff and smiling and laughing, right?
They are the redirectors.
Yes. So we have kind of this opposite issue in that the task-related things are really challenging for young kids with Down syndrome, and requesting is a really important skill to establish early on. Exploratory motor kinds of things. So engaging with materials, manipulating. And again, that might also be influenced by some of the muscle pieces, right? Where it's hard to manipulate objects. So working on exploring that. And then those task-related consequences. So just like I might pair tangibles or tasks to try and increase the value of social reinforcement or social consequences for kids with autism, I might pair social consequences with task-related consequences to try and increase the value of those things. Yeah, that's a big piece, is like definitely requesting, and that's manding. Is always important for everyone. Getting the stuff you need.
So what are you working on now? Like, what's the latest projects? I know you mentioned briefly when we were talking maybe a month or so ago that you were working on you were involved in a manual of some sort for early intervention.
Yeah, that came out. There's called Off to a Good Start. There's a behavioral manual for 0 to 3 intervention for kids with Down syndrome that covers all those specific phenotypic strengths and weaknesses so that you can pull out program. It's very much I don't want to make it seem like it's super amazing, but it's the Gina Green style of like, it's got a list of programs that you can kind of pull out and use to develop focused interventions for little guys with Down syndrome. The cool part, right, is it's 0 to 3. Like, that's before any kid with autism is diagnosed, right? So
100%.
That's what early intervention is for genetic disabilities that are obvious.
Yeah, because you can start the moment, right away. Yeah.
And I had a friend who did like babbling work with kids with Down syndrome too, right? So there's some cool things that you can do when you get them really young.
And are these sort of intended to be kind of parent implemented?
Yeah. So the book is designed probably for like parents mostly. If you have behavioral knowledge, you could probably skip the first book and just take the second one, which is the list of programs. So the first book is more sort of the theory kind of stuff and introduces families to prompting and shaping and reinforcement and all of that kind of stuff. And then the second part is the programming. So if you have that knowledge already, probably the first part is less beneficial, except maybe the descriptions of Down syndrome and learning about the diagnosis. But the second has like just all the programming written out.
So that's already done. So that wasn't the answer to the question then. What are you working on now?
So some of the stuff we're doing, I have a few students that are working on some online parent training kinds of pieces and looking at these kinds of, one is some sibling work. Mm-hmm. So doing some like stay, play, talk kinds of things with individuals with Down syndrome mediated through an online platform, as well as through some synchronous coaching. So some asynchronous, some synchronous kinds of things. Mm-hmm. I have a grant right now that's looking at inclusive education and inclusive practices in informal settings. So informal being outside of school settings. So museums, camps, those kinds of things. So we have a host of projects related to that. So looking at, what are policies and procedures and things in place that would target people with intellectual and developmental disabilities, yep, and present facilitators or barriers for them, working on some training kinds of things.
Awesome.
But working in that third space.
Yeah, I see some, there's obvious value just for, the families and the, and the people with disabilities, but I imagine that's also going to be a really sort of cool way of kind of educating the world.
Yeah. Yeah. And right. Like, I don't know, when you think about your childhood, the stuff that you carry around, right? It's like, it's going to camp. It's going to the museum. Like those are the ones I feel like are those things that you hold on to. So thinking about inclusion in those spaces, like we're not really included until we get into all of those spaces, those community spaces as well.
Yeah, for sure. Well, before we kind of finish off, I was just wondering if there's sort of, just for folks out there listening that may, get their first client with Down syndrome, probably not in an early intervention setting, maybe in a school setting, or, out here in British Columbia, we have a lot of folks that work with these call them kind of globally funded contracts where basically you're getting a family that doesn't even know what a behavior consultant is, and for whatever reason you've arrived at their home, and maybe your background is mostly autism. What are some things you might just kind of want to say to these folks?
Yeah. For me, I probably wouldn't say anything. I'd probably want to listen to them first. So I think really getting to know the family and the strengths and about the child, the techniques, like the behavioral techniques are going to be the same or similar, but don't pull from your standard, like, oh, we need to work on X, Y, and Z, because that's what I always go in with. So I think really listening and seeing, what are their strengths, what are their needs, and learning about their diagnosis, and then learning about how that diagnosis interacts with their whole context. So how does that affect their parents, and how does that affect the individual, those kinds of things. And then using those strengths in the context of your intervention or your behavior plan, right? So a lot of listening is going to be helpful to figure out what to do there.
And what would be a good place? Obviously we've got your research, and I'm going to share all that in the show notes. But beyond that, what would be some good places for folks to kind of start just learning more about Down syndrome?
Yeah, I think if people want to learn, there's some really good developmental literature out there. So one of the big authors is going to be Deborah Fidler. So if you want to learn about that behavioral phenotype, the strengths, the challenges, the functioning, all of that is really nice literature that they've looked at the development, and she's done a ton of work in there. There's also some stuff by Dykins and Finucane on incorporating the behavioral phenotype into behavior analytic kinds of approaches. So blending those ideas together. Those are some good ones to look at. There's a textbook related to that's I think is a really good overview of different genetic syndromes, and then thinking about some possible intervention avenues.
Is that Canadian one? Is that the one you're talking about?
No, this one is older, but in a similar vein.
Perfect. Well, that's awesome. Well, Nicole, thanks so much for being on the podcast today. I mean, I think we learned just a ton of really, really interesting things and cool things about working with folks with Down syndrome that, that I don't think we ever would have thought about. And I think often folks are just kind of going in and applying things from an autism lens, because that's sort of where a lot of their training was. And so this stuff has been, I think, really, really helpful and can really help kind of guide folks in the right direction. So thanks so much for being on today with me.
Yeah, thank you for having me.
Super cool. All right.